I want to welcome you to the Dementia Mini Didactic. I'm Dr. Steve Barzey, a geriatrician who practices within the Madison VA Geriatric Research Educational Clinical Center with additional appointment at the University of Wisconsin School of Medicine within the Division of Geriatrics. And over these coming minutes, I'm going to walk you through some core principles in management of a common geriatric syndrome, dementia. Memory complaints and dementia are particularly relevant in an aging population, especially when we're serving older veterans. In the course of this mini didactic, I'd like to cover a couple of key things. Start out by just reminding you that the Geriatric Scholars Toolkit is an invaluable resource as you are refining your clinical skills in the practice of care for older adults. We're going to talk about three categories, or three basic buckets, if you will, that represent different types of memory complaints that would be present. Focus on some key aspects of history, some basic elements of workup, and finally finish up by talking about some core aspects of a basic dementia care plan. When we interact with older adults, who do we evaluate? Do we consider everyone above a certain age, above 65, above 85? Well, the evidence from many resources and research studies suggests that to date, we should not do mass screening for all older adults above age X. In fact, the VA, as well as the U.S. Preventive Services Task Force, do not recommend such mass screening. However, when we're interacting with a situation where a patient themselves, possibly a family member or a friend or a member of the healthcare team, express a concern, then that's no longer primary screening. And in any of those situations, we would proceed with evaluation. And when we do, we can't use our own clinical instincts alone. We have to measure. It's crucial we use some form of objective test. And we'll talk about these tests in a little bit. When we think about patients who have a memory complaint, it's important for us to divide them up into different categories or buckets, if you will, because they don't all have the same trajectories or the same prognosis. All of us will, starting at about age 30, develop some type of age-related inefficiency in our memory. This slowing of the speed of pulling out information, possibly the increased difficulty with learning new information, as well as the ability to divide attention or do what we call multitasking. All these things change as we age. However, when you do objective testing with an individual with age-related change, then you don't typically find that they fall outside the norms. And the most important thing is in this group, they do not have evidence for interference with their day-to-day life, that is their functional status, or social interactions. There's another group, a group that we call mild cognitive impairment or mild neurocognitive disorder. And again, this group has subjective complaints. In this situation, though, when we proceed with some type of testing, there is objective evidence that the person is falling outside of the norms in one or possibly several cognitive domains. This is a group that can have very different trajectories. Some of them may have confounding medical or substance factors that could be interfering, and in those that with improvement and management in those issues, they may go back to that normal age-related changes bucket. On the flip side, we know that upwards of 10 to 12% per year will convert into the third bucket, dementia, which we'll talk about in a moment. The crucial thing with MCI is that these individuals also do not have impairment in any of the functional domains, in social interaction, and they've compensated so that it's not interfering with their day-to-day life. Now, the third category. And this is a category that obviously we all pay a lot of attention to because we know that it can have a progressive and negative trajectory. This is a group that we would call dementia or major neurocognitive disorder. And there are various criteria, but suffice it to say that a person needs to have objective abnormalities in memory and at least one other cognitive domain. And that could be executive function, it could be attention, it could be language skills. And these objective abnormalities coexist with evidence for impairments in instrumental or basic activities of daily living. And so in this situation, I think it's valuable to recognize that not all IADLs or ADLs drop off equally fast. And it's valuable as we start to explore a person who might have dementia to understand, are they managing their medications, which happens to drop out early? Are they having problems with managing their financial situation, also dropping out early? Are they having difficulties with driving? This also is a third category that drops out very early. So we should be thinking about that. When we have a suspicion that a person is either mild cognitive impairment or dementia, it's valuable that we organize the possible etiologies. And we know now that many sensory factors can interfere. Depression and anxiety can confound a person's ability to learn and remember and can produce a pseudo-dementia, if you will. Sleep disturbances such as sleep apnea and other sleep problems. Medical conditions sometimes can cause acute delirium or confusion. And finally, a number of different medications and substances that are used can interfere. So all these things need to be considered above and beyond a neurodegenerative process like vascular dementia or Alzheimer's dementia. As we interact with individuals who complain of memory problems or have others who are concerned about their memory, it's very important that we think about risk factors and we ask about these risk factors early in the interaction. So, as I mentioned, advanced age can be a contributing factor. In fact, above age 85, the prevalence of some form of cognitive impairment is approximately 40%. It's valuable to understand, does a person have a family history of some form of dementia or memory problem? Have they had significant head trauma or loss of consciousness earlier in life? Do they have established vascular disease? And this may or may not include cerebrovascular events such as stroke. Have they had onset of depression in later life? And does this depression seem to be hard to respond to treatment? And finally, are they using various substances, alcohol or chronic use of hypnotics or sleep aids, since all of these things seem to contribute towards increased dementia? As mentioned at the beginning of the introduction to this whole series, there's some very informative and useful tools, if you will, within the Geriatric Scholars community and specifically within the toolkits area of the Scholars website. So as you can see here, you would go to the Geri Scholars community website, and then from here you would move to the Geri Scholars program, and then you would move further to the location of the toolkits themselves, which is here on the screen. Within the toolkits, of course, there's a whole host of geriatric syndromes, but today we're focusing specifically on dementia and dementia care. And I'll outline for you that there are a number of valuable little PDFs that are available. They include things such as orienting to some of the common brief cognitive tests that you might use. The VA slums test being one that is probably the easiest to use, although the Montreal Cognitive Assessment, the MOCA, can be very helpful too. To be aware, the MOCA may have some specific requirements for additional training before one can use it in the not-too-distant future. But there are other tools such as the mini-cog, which is quite brief. There's the Blessed, which is used most commonly by psychiatry and by mental health. And then there are other tools which I'm not going to be advocating. Within the dementia categories and such, it's valuable to know that there are what are called GEM tools. And these GEM tools are actually part of the Geriatrics Care Online programming within AGS. And specifically, if you go to dementia, which is one of the geriatric syndromes we're focusing on today, then you can upload and can access this kind of information also. But coming back to the Geriatric Scholars Toolkit, within the toolkit itself, there are, as I mentioned with dementia, there are some valuable kind of overview topics that include some discussion about the determination or the discernment between three commonly coexisting or potentially coexisting processes of delirium, dementia, or depression. And as you can see on the screen here, there are ways by which we try to determine between these phenomenon. Suffice it to say, for this mini didactic, delirium is acute, abrupt change in cognition with attentional difficulties and also distortion in thinking, processing, and fluctuating levels of consciousness. Jumping back to the Geriatric Scholars Toolkit, and specifically to the dementia section, I want to then direct you down to beyond these brief cognitive tests. There is a section that's called Clinician Fact Sheet Detection of Dementia. And this particular tool, which gets into a couple of key concepts. Number one, what the dementia warning signs represent. And as you can see here, there are various things that clinicians or possibly clerks or others within a health system might notice with patients relating to their dress, relating to whether they are or not making their appointments, how appropriate they are with getting on time, their ability to engage family and to follow through on various tasks. So, and this is all outlined here in the section to the right. Moving down further, if you do have a concern that a person may have an underlying cognitive difficulty, then it's important to sort out some historical details that'll help to further clarify what might be going on. So here in this section, it gets into certain focused historical details. And these are details I'm sure that you have heard of before and people have talked about. But I want to point out a couple of them that people sometimes tend to forget or miss during their normal exchange with the patient and or their family. Specifically, the onset in the course of symptoms is a pretty logical thing, so I'm not going to get into more detail about that, but it is important to get a feeling of how long ago things were apparent. That issue I was talking about before, specific to the circumstances of if a person is having a learning disability or some kind of a prior deficit that happened years prior. So that head trauma, underlying psychiatric diseases, established vascular diseases, and vascular risk factors can all give us important hints as to what the etiology might be for a particular memory complaint or cognitive change. It's also very, very important to consider substances. And although it's listed here as alcohol use, and marijuana use may be things to consider, even if that wouldn't necessarily be something you would suspect in that frail older woman who reminds you of your grandmother or grandfather. Medication review is important, and I want to emphasize in this area that over-the-counters, do not forget over-the-counters. Patients will oftentimes provide you a list. It might be a list in front of you in CPRS or in the health record, but they may not automatically think about that over-the-counter antihistamine or that sleep aid that has an antihistamine in it, which we know will definitely influence a person's cognition. In all geriatrics, it's valuable to get a sense of what the person's functional status is like. In other words, what are their instrumental and basic activities of daily living. And it goes beyond the scope of this brief talk as to all of the IADLs and ADLs, but be aware that some of the IADLs drop out earlier. Patients tend to have more problems with money management, with medication management, and with driving. And so even if you can't ask the full functional history, definitely ask about those three areas. From here, it's valuable to understand what are important elements of a focused examination and what additional laboratory information and, if appropriate, imaging or neuroimaging might be justified. As detailed on the screen here, if one has limited time, it still is very valuable to obtain basic cardiovascular exam, neurologic exam, as well as mentioning previously some type of cognitive or mental status assessment. Amongst various laboratories, the VA and other national guidelines suggest that at baseline we collect TSH, we collect some electrolytes, we collect chemistries that might include BUN, creatinine, a B12 level, folate, and in other situations things such as liver functions or urinalysis. Some individuals even endorse other vitamin levels such as thiamine or vitamin B1 if a person is a drinker, or if a person has a very poor diet, then B2 or B6 can also be important. The issue of imaging is a complicated one, but suffice it to say that if a person's had an abrupt change, then it's almost always justified to obtain some type of imaging, whether it be CT or an MRI. If a person hasn't had an abrupt change, but they have an unusual picture, then once again it can be valuable. Lastly, if you have concerns that a person might have had a cerebrovascular event as a contributing factor, then to assess what their underlying vascular status is within their CNS, it can also be valuable. Shifting from the diagnosis or evaluation of a patient to formulating a care plan and then educating the patient and family is an important transition. When you have a sense about what may be going on, then it becomes very delicate yet important for us to tell the truth or inform the patient of the diagnosis with certain caveats. Clearly, truth-telling, though, can be one of the most challenging aspects of a patient interaction. In some cases, it's reasonable to share that we still have to gather more information. In other cases, when we really have a sense of what's going on, then it's important to explore with the patient what they and their family already understand, what they've been told before, and equally to investigate what they want to know. There are cases where patients and family members don't really want to know the diagnosis. Assuming, though, that patients and family are receptive, then I think it's important to frame the dementia syndrome as a chronic condition or chronic illness, just like heart failure, diabetes, or lung disease. Certainly with these chronic conditions, there are different trajectories, and those trajectories can be modified based upon intervention for various factors. In dementia, for example, we think about a lot of the reversible or modifiable factors, such as medications, unrecognized or untreated sleep disorders or mood disorders, inadequately addressed substance use issues, sensory issues that are substantially interfering with the intake of information. So it's reasonable to say there is dementia present, and like other chronic conditions that people live with, there are ways that we can change the trajectory of this illness. That provides information yet also hope. With regards to the basic principles of dementia care or a dementia care plan, in the end, we're trying to help the patient and family live the best that they can with a serious illness. As I mentioned before, one of the key issues is addressing modifiable factors, and a lot of the initial care plans should focus on this, considering medications, considering sleep disturbances, considering mood difficulties such as unmanaged or undermanaged depression or anxiety, addressing sensory barriers such as hearing impairment or sometimes visual difficulties too, and then appropriately managing vascular risks. And notice I mentioned appropriately managing because we can harm patients just as much by over-treating them for their diabetes or for their hypertension as we can by not treating them. So the patient with hypotension or the patient with a particularly low hemoglobin A1C may suggest that we could in fact at times be placing their brain at risk by hypoglycemia or by inadequate CNS perfusion. Besides discussing and addressing modifiable factors, it's important to start the process of coordinating care that will prevent some of the potential medical and psychosocial complications. And all along the way, educating patients and families, and even re-educating them at different stages of the illness. With education, I think it becomes very important as you're interacting with a patient to write things down. When you get done with an interaction with a patient, especially with someone with cognitive impairment, if they don't walk out of the office with some basic and simple summary of what was detected and what is recommended, then we have failed our patients. It's not we individually, though. It's key that we recognize the value of the interdisciplinary team in providing effective care coordination. So during the course of discussing a care plan, if you've not considered engaging other team members, whether it be a social worker, a nurse care manager, potentially a pharmacist, to help with the process, again, you may be making your task more difficult. It's also valuable for us to start to anticipate what the community needs might be, what the home safety needs might be, if there's a role for a rehab specialist such as a physical therapist or occupational therapist. And all encapsulating this in the care plan, which, again, hopefully has been written down, especially if there's been more than 3 or 4 recommendations made. With regards to areas that people may forget when they create their care plans, they may dance around the complicated issue of driving. They may not address what kinds of behavioral factors might already be confounding or interfering with the patient's regular day-to-day care. We may forget to ask about firearms in the home and the security of those firearms. We might not consider home appliance adjustments, adjustments of water temperature in the home or other things to prevent scalding. and we may overestimate the patient and or their family's ability to appropriately administer medications. So all of these things turn out to become very important elements in a care plan. So in the end, we're creating a care plan that's going to be individualized for the patient, that's going to engage other team members, that's going to be thinking about the psychoeducation, thinking about the non-pharmacologic, but then also is going to think about the pharmacology from two perspectives: removal of medicines that might be harmful, and potentially adding medicines that might modify the memory difficulties, at least transiently. I don't get into a lot of discussion today about some of these agents such as donepezil or rivastigmine and the like, but they do have a modest effect. In the end, we want to empower the patient though, and we want to empower the caregivers. So if the caregivers aren't there, we want to reach out and connect with those caregivers when we can, either ourselves or other team members. So I hope this information was helpful and that you can take some of these core principles or approaches and incorporate them into your day-to-day practice, because we are here to serve our patients, serve our veterans, and we can make a difference.